Okay, we're going to continue with NICU Part 4. I am going to go over fetal alcohol syndrome. This is the leading cause of mental retardation, hyperactivity, poor coordination. It is often experienced, the child will experience growth restriction, behavioral or cognitive difficulty, or developmental delay. Facial features are normally short, palpable fissures, broad nasal bridge, short stature, beak-like nose, small head, small maxilla, thin upper lip, smooth philtrum. It also affects the heart, the eyes, the ears, the kidneys, the joints. They tend to be poor feeders. They have little interest in eating, and they could have CNS dysfunction. So let's talk a little bit about the care of the drug-dependent newborn. So what do mothers abuse? Usually a drug-dependent newborn is because mothers abused everything. So the nursing goal will be to reduce withdrawal symptoms, promote adequate respirations, temperature, and nutrition. Treatment will depend on the drug that was involved, the infant's overall health, whether the baby was born full term or premature. The healthcare team will watch the newborn carefully for signs of withdrawal, feeding problems, and weight gain. Babies who vomit or who are very dehydrated may need to get fluids through a vein, such as an IV. Infants with neonatal abstinence syndrome are often fussy and hard to calm, and tips to calm the infant down include gently rocking the baby, reducing noise and lights, swaddling the baby in a blanket. Some babies with severe symptoms need medicines such as methadone and morphine to treat the withdrawal symptoms. The goal of treatment is to prescribe the infant a drug similar to the one the mother used during the pregnancy and slowly decrease the dose over time. This helps wean the baby off the drug and relieve some withdrawal symptoms. Breastfeeding may also be helpful. Babies with this condition often have poor feeding or slow growth. These babies may need a higher calorie formula that provides greater nutrition. Smaller portions are given more often. Treatment helps relieve symptoms of withdrawal. Some of the risks to the newborn related to the drug-abusing mother are intrauterine asphyxia. It's usually because of hypoxia, because the abusing mom has a higher likelihood of abruption, preeclampsia, and etc. Then we have intrauterine infection and infections such as Hep B, HIV, or herpes. There's changes in birth weight. Moms who abuse heroin often have a small gestational age baby, and then moms on methadone may have large gestational age babies, though they can have risk of low APGARs. This relates to the intrauterine asphyxia or medications mom took prior to coming to the hospital. They can experience respiratory distress, usually due to meconium aspirate or TTN. They can experience jaundice. Preemies are actually more disposed to jaundice than term babies, and most drug-abusing moms will actually deliver early. And then we have congenital anomalies or growth restrictions. Congenital anomalies could be because of drugs, because of the microcephaly, intrauterine growth restriction, genital urinary defects, SIDS, poor behavioral state organization. They can't move smoothly from sleeping to awake, and they can't handle stimuli at all. Some behavioral issues tend to be that the baby tends to be very irritable. And then withdrawal syndrome, the symptoms usually begin around 24 to 48 hours. Such as irritability, high-pitched cry, tremors, poor feeders, vomiting, diarrhea, poor suck, or nasal stuffiness. Okay, so for treatment, we're going to do a urine or meconium drug screen. We're going to have a social service consult, a newborn crisis assessment, may have the neonatal abstinence scoring, or we will have the neonatal abstinence scoring. We're going to treat withdrawal with a phenobarb, methadone, or oral morphine. We're going to provide pacifiers, feeds, and then the child usually ends up on a soy or lactose-free diet. We're going to swaddle tightly. They can actually have temperature instability, so we want to monitor for that. They can have seizures, and they can have vomiting. They'll get drug butt, per se, which is a horrific diaper rash and constant diarrhea, and we want to keep their surroundings or environment dark and quiet. Okay, so this is a neonatal abstinence score sheet, and I think we talked about this in a previous lesson, but it covers the central nervous system disturbances, the metabolic, vasomotor, respiratory disturbances, gastrointestinal disturbances, and then basically you look at those and you score based on where they're at, and then they get a total score as far as what their score level will be. So remember in previous lessons we discussed the neonatal abstinence scoring system. It's proposed by Finnegan, which is used widely in neonatal units to initiate and to guide therapy in babies of opiate-dependent mothers. Score 1 for least potential for adverse effects. Score 5 for most potential for adverse effects. No pharmacological therapy is total score of 7 or less, and then pharmacologic therapy is score of 8 or more. Okay, I'm going to briefly talk about the infant or mother with HIV or AIDS. Often these babies are born SGA or premature. The infant or the mother who has HIV or AIDS receives the same care as all newborn infants. Additionally, nurses will include to protect the infant from opportunistic diseases. You want to keep the newborn well nourished to prevent failure to thrive, encourage immunizations, and monitor for thrush or signs and symptoms of infection. So babies can be tested at birth, then again at 1 to 2 months, and again 4 to 6 months. You want to take standard precautions when you're drawing blood samples. Wear disposable gloves when changing diapers. Place diapers in a sealed plastic bag and dispose of daily. You want a clean changing area with 1/10 bleach solution after each diaper change. Skin care to prevent skin rashes. For term babies, start AZT 2 milligrams per kilogram per dose. PO every 6 hours at 8 and 12 hours of life, and then continue for 6 weeks. If baby is HIV positive, switch to multi-drug antiviral regimen. And if baby is still negative after 18 months, then the baby likely won't acquire it. This concludes part 4 of NICU lessons.